honor to share you with the lesson of Radiology of Digestive System. I'm Lily Wang from Department of Radiology, Union Hospital, Fujian Medical University. The contents of this lesson contains two major parts. The first part is the introduction of the upper abdomen, including the basics, imaging modalities, normal upper abdomen anatomy, and organomegaly. The second part is about the common diseases of the upper abdomen organs, including pancreas, liver, biliary, and spleen. The basis of the imaging of the upper abdomen is that history and physical examination continue to be an essential part of evaluating abdominal abnormalities, not only to suggest an etiology, but also to help determine which, if any, imaging study will provide the best yield in establishing the correct diagnosis. Conventional radiography, ultrasonography, CT, and MRI are all utilized in the imaging evaluation of abdominal abnormalities. Each method has advantages and disadvantages inherent to its own particular technology, and the choice of modality is frequently based on the patient's clinical condition. Conventional radiography is primarily used for screening in abdominal pain. However, it's a lower sensitivity method. And ultrasonography is primary imaging mode for gallbladder and biliary tree. However, it's operator-dependent and more difficult to interpret. CT is a diagnostic modality of choice for most abdominal abnormalities, including trauma, and it usually needs full contrast administration. And when people in a situation of inability to use full contrast, CT examination cannot be used. And MRI is usually used as a problem solving for difficult diagnosis. It's good at soft tissue contrast. However, it needs longer scan times, and patient weight and size may degrade or exclude scanning. Here is an image of normal upright abdomen. Normally, there is an air fluid level in the stomach. However, soft tissue structures in the abdomen are lack of natural contrast, so we cannot exactly depict it liver, spleen, or pancreas. And conventional radiography is a lower sensitivity method in diagnosis of the disease of upper abdomen. CT evaluation of liver masses is usually done with a combination of scans obtained before and after intravenous contrast injection. Combination scans obtained before and after intravenous contrast injection. This combination of 3 separate scans done without contrast and then during the hepatic artery phase followed by portal venous phase is called triple phase scan. This is very important. Triple phase scan is the basement for liver masses differential diagnosis. You should remember what's the triple phase scan. It contains 3 separate scans, including the non-contrast, non-enhanced scan, and then the hepatic arterial phase and also portal venous phase. Here is an example of triple phase CT scan of the liver. Image A is the unenhanced image. We can see the mass located in the liver, and in image B is the artery phase. We can see the enhancement tumor, and in image C is the portal venous phase, and we can see the flush out phenomenon of the tumor. And the combination of these 3 scans is called the triple phase scan. Liver MRI is particularly useful in the evaluation of small lesions, especially smaller than 1 centimeter compared to CT. And the contrast material of liver MRI is gadolinium. And also it uses multiple enhanced images, and also named triple phase scans. The spleen is usually about 12 cm long, does not project substantially below the margin of the 12th rib, and is about the same size as the left kidney. Liver is divided into the right lobe, the left lobe, and also the caudate lobe by its vessels. And the right lobe is also subdivided into 4 segments. In this slide, we can see the ligamentum teres divide the left lobe of the liver into the medial. Here is the medial and the lateral segment. With the larger right lobe, here is the right lobe lying more posterior. Let's review the anatomy of the pancreas. The pancreas is a retroperitoneal organ oriented obliquely so that the entire organ is not seen on any one actual image of the upper abdomen. The tail is the most superior, and then the body part of the pancreas, and then the neck part of the pancreas. and then the head part of the pancreas. The head and the neck are on more inferior slices. The head of the pancreas is nestled in the duodenal loop, and inside the pancreas there is a main pancreatic duct, and it empties into the duodenum. Here is the main pancreatic duct. The liver normally displays all bowel gas from the right upper quadrant. Occasionally, a tongue-like projection of the right lobe of the liver may expand to the iliac crest, especially in females. This is called a radial lobe and is normal. Conventional radiographs are notoriously poor for estimating the size of the liver. CT, MRI, or ultrasound give a more accurate picture of liver size. The enlargement of the liver is named hepatomegaly. Sometimes the liver can become so enlarged it will be obvious even on conventional radiograph. An enlarged liver might be suggested from conventional radiographs if there is displacement of all bowel loops from the right upper quadrant down to the iliac crest and across the midline, as in this patient with cirrhosis. If the spleen projects well below the 12th posteriorly or displays the stomach bubble toward or across the midline, the spleen is probably enlarged as it is in this patient with leukemia. Today we will talk about the anatomy, important signs, and characteristics of common disease of pancreas, liver, biliary, and spleen. First, let's take a look at the pancreas. In this class, we will talk about two kinds of pancreatic diseases. One is pancreatitis, the other is pancreatic adenocarcinoma. We should remember that the two most common causes of pancreatitis are alcoholism and gallstones. The inflammation of pancreatic tissue leading to disruption of the ducts and spillage of pancreatic juice occurs readily because of the lack of a capsule surrounding the pancreas. In this CT image, we can see spillage of pancreatic juice. Pancreatitis is a clinical diagnosis because patients usually have abdominal pain and elevated amylase. And CT can be used to document either a cause or a complication, for example, pseudocyst formation. Acute pancreatitis is broadly classified as mild or severe acute pancreatitis. Mild acute pancreatitis is also named interstitial pancreatitis. And differential diagnosis between mild and severe acute pancreatitis requires full contrast administration. The right side CT image of the pancreas indicates that the enlargement of the pancreas. We can see the pancreas is enlargement, and also the fluid collections. Here are the fluid collections around the pancreas, and after contrast enhancement, it's homogeneous. Here is an example of CT findings of acute pancreatitis. This is a non-enhanced CT scan, and we can see an enlargement pancreas. Here is the enlargement pancreas, and there are large heterogeneous peripancreatic fluid collections. This area and also this area are fluid collections. Inside the ground, the necrosis cannot be ruled out because this is a non-enhanced CT scan, and we have known that the differential diagnosis needs full contrast enhancement. And after contrast enhanced, we can see the CT scan reveals two zones of liquefied pancreatic necrosis in the neck part of the pancreas and also the tail of the pancreas. We can also see residual nodular areas adjacent to the tail of the pancreas. It's consistent with fat necrosis. In this case, we can see a typical acute pancreatitis. First, we can see the body of the pancreas is enlarged, and there is infiltration of the peripancreatic fat in this area. And these findings are consistent with acute pancreatitis in a proper clinical setting, for example, elevated amylase and lipase. This is also an example of severe acute pancreatitis. We can see an encapsulated fluid collection. Here is the encapsulated fluid collection, and also we can see the liquefied necrosis in the body of the pancreas, but the head part of the body and the tail of the pancreas are still enhancing. And also we can see the fluid collections, also consistent with fat necrosis, are seen adjacent to the pancreas. MRI is an alternative in situation in which contrast-enhanced CT is contraindicated, such as in patients with contrast allergy or renal insufficiency. In image B, we also can see fluid collections detected in the peripancreatic collections. Here is also a fluid collection. MRI was found to be equivalent to contrast enhanced CT in helping assess the location, the extent, and also the degree of the pancreatitis. In these images, we can see increased signal intensity of pancreatic fat tissue. Here, it indicates the fluid collections. And also in coronal images, we can also see the increased signal intensity indicate acute pancreatitis. Pseudocysts of the pancreas occur when fibrous tissue encapsulates a wall of collection of pancreatic juice released from the inflamed pancreas. Pseudocysts may have an enhancing wall. This area is the enhancing wall of the pseudocyst. And the cyst is indenting a loop of agitation bar. In this case, the posterior wall. Here is the posterior wall of the stomach. The indentation on the loop of bar by an extrinsic mass is called a PET sign. Here, a loop of bar, in this case, a loop of the poster wall of the stomach, and plus the extrinsic mass. This sign is called the PET sign. Here is an example of a typical pseudocyst. It's a uniform low attenuation fluid collection with the same uniform wall located in the tail part of the pancreas. When cysts are chronic, the cyst wall can calcify. Here we can see the calcified wall. This is the calcified wall. Chronic pancreatitis is a continuous and irreversible disease of the pancreas, most often secondary to alcohol abuse and leading to fibrosis, atrophy of the gland, and also ductal dilatation and frequently diabetes. In acute pancreatitis, the gland is enlargement, but in chronic pancreatitis, the gland is atrophy. And acute pancreatitis and chronic pancreatitis are assumed to be different disease processes, and most cases of acute pancreatitis do not result in chronic diseases. This is an example of chronic calcific pancreatitis. Image A is the conventional radiograph, and image B is the actual CT scan. In image A, we can see a close-up view of the left upper quadrant of a conventional radiograph of the abdomen shows amorphous calcification. In the middle area of the image A, we can see amorphous calcifications, implying calcification in a solid organ or tumor. The anatomic distribution of the calcification corresponds to the pancreas. And image B, in another patient, a non-enhanced image of the upper abdomen shows calcifications. These obvious white areas are calcifications inside pancreas, distributed along the course of the body and tail of the pancreas. And these areas are hollow contrast inside the stomach. These calcifications are pathognomonic of chronic pancreatitis, a chronic and irreversible disease that leads to atrophy of the gland and diabetes, occurring mostly secondary to alcoholism. The hallmarks of the disease are multiple amorphous calcification that form within the dilated ducts. We can see here are the dilated ducts of the atrophied gland. We can see the pancreas is atrophied, and also the dilated duct and the calcification inside the dilated duct. These are the hallmarks of the chronic pancreatitis. Pancreatic adenocarcinomas accounts for 75% of all pancreas cancers, and it has an exceedingly poor prognosis. Here we can see an example. The pancreas is bisected along its longitudinal axis and revealing the large adenocarcinoma of the head. Approximately 75% of all pancreatic adenocarcinoma occur within the head and neck part of the pancreas, and 15 to 20 occur in the body of the pancreas, and 5 to 10% occur in the tail. And about half of the patients present with jaundice, most of the time there is associated pain. Ultrasound is often the initial test in symptomatic patients. It's used for diagnosis rather than staging. Here we can see an enlarged head of the pancreas, and this is the adenocarcinoma. On ultrasound, pancreatic tumors are seen as hypoechoic mass lesions that become more heterogeneous in echo texture with increasing size. Features suggestive of underlying pancreatic cancer, including the following. First, focal pancreatic mass, usually hypodense to the remainder gland, and ductal dilatation, usually involving both the pancreatic and biliary ducts. And other findings of the pancreatic carcinoma include spread to contiguous organs enlarged lymph nodes and ascites. This is a typical case of pancreatic adenocarcinoma from your book. We can see the cancer is located in the head of the pancreas. In this transverse CT scan, we can see the head of the pancreas is enlarged by a mass. Normally, the head of the pancreas should roughly be the same size as the width of the lumbar vertebral body visible on the same chart. Most pancreatic adenocarcinoma are located in the head area. About 75%, and jaundice is a common presenting sign. This is an example of pancreatic adenocarcinoma located in the neck part of the pancreas. And then the tumors are small. They especially smaller than 2 cm in maximum diameter. They can be confined to pancreas. And here we can see a small tumor located in the neck part of the gland. Here is an example of advanced pancreatic adenocarcinoma. This tumor is bigger and it's located in the head part of the gland, and it has been warped common bile duct in the perineal stent, and that it extends medially beyond the confines of the pancreatic head. However, the tumor is separated from superior. Here is the superior mesenteric vein and also superior mesenteric artery by a fat ram. Here is the fat ram. But the tumor has involved the duodenum. Here is the duodenum, and we can see the tumor has invaded the duodenum. Here is an example of pancreatic adenocarcinoma invaded the celiac axis. This is the celiac axis, and also the splenic artery, and also the common hepatic artery. And this tumor cannot be resected by surgery because it has invaded the celiac axis. In MRCP images, we can see the hallmark signs of pancreatic adenocarcinoma node double dot site. Double dot site. You should remember this time. It's because of the pancreatic duct obstruction in the head with proximal dilatation of both pancreatic duct. Here is the pancreatic duct and also common bile duct. And this site is referred to as the double dot site. Here, usually tumor located here. Here is the pancreatic adenocarcinoma, and it and because of the tumor, we can see the obstruction of both the two ducts, including the pancreatic duct and also the common bile duct. And this site is named double dot site. In T1 MRI images, we can see a tumor located in the area of the inferior area of the common bile duct. This tumor, it encases and narrows the celiac axis. This is the celiac axis, and also its branches, and also partially envelopes the aorta. Here is the aorta. So this is a non-resectable carcinoma.